Hello, everyone. My name is Jill Williams, and I'm going to be speaking with the TICTAC team on implementing treatment of tobacco use disorder in New York City behavioral health programs. This is an introductory webinar that doesn't take the place of intensive training, but provides an overview of key concepts related to the treatment of tobacco use disorder. Some of the learning objectives for today are to understand the numerous consequences of tobacco use in those with behavioral health conditions, including effects on mental health and substance use, to recognize that tobacco treatment works, yet is not being routinely delivered in US behavioral health programs, to understand that tobacco use disorder is an addiction and should be treated as a co-occurring disorder, to become familiar with basic components of tobacco assessment and treatment, and to understand how the New York City TICTAC program works to provide training and technical assistance to behavioral health programs in New York City to help increase their capacity to address tobacco. These are the members of the team, some of whom you may be familiar with. It includes Dr. Nancy Koval, Rusty Foster, and Noah Lipton, and you'll be hearing from them later today. So just to start with some basic statistics, US smoking really is at an all-time low. In fact, this data is a few years old, but smoking rates in New York State are quite low, among the lowest in the country, around 13 or 14%. Perhaps that's much lower than what you would have guessed. You can see that there's a little bit of variation in the boroughs, with New York City having a slightly lower smoking rate than the rest of New York State. And that variation in between the boroughs is largely linked to socioeconomic status. That's one of the factors that's very important in understanding higher rates of smoking. Higher rates of smoking are associated with those with lower measures of socioeconomic status. Smoking rates are consistently higher in populations with behavioral health comorbidity. This is showing also data from New York to show an estimate of serious mental illness, which is called SPD, or serious psychological distress. And you can see at each of these time points, rates of smoking are higher in those with serious mental illness compared to the rest of the population. They're trending downwards somewhat. There is some promising data that suggests smoking rates are going down, even in those with behavioral health conditions, but still not at the rate of decline that we see in the general population. We can think of smoking then really as a social justice issue because it affects our most disadvantaged populations, those who experience other kinds of health disparities. We know that big tobacco traditionally has targeted these vulnerable populations, including people with behavioral health issues. And we now know that not only are smoking rates higher in these populations, but in fact, they remain a considerable portion of the market for tobacco, buying almost half of all the cigarettes sold in this country. When we talk about smoking, we really say it's the smoke that kills. There's a lot of toxins contained in cigarette smoke, but there's actually 3 different sources of toxins that you get from tobacco exposure. Nicotine, of course, is naturally occurring in the tobacco plant, but there's a very important carcinogen called nitrosamines, which are also contained in the plant. That helps us understand why all kinds of tobacco carry the risk for cancer, because essentially the carcinogens are in the plant. There are chemicals that are added during the cigarette manufacturing process that change the way tobacco smells and tastes and burns. There's a lot of discussion now about banning flavoring agents from tobacco. But in fact, most of the toxins come from when you take tobacco and you light it on fire. That's called combustible tobacco. That creates thousands of new chemicals, and many and most of the toxins that we think about that are linked to smoking exposure. You may know that tobacco causes a considerable amount of medical morbidity and mortality, including premature death, The big diseases that people get from tobacco smoke exposure include heart disease, lung disease, and many types of cancers, but those are not the only illnesses that you get linked to tobacco. It also can worsen your experience with COVID. If you acquire COVID, you'll have a more severe illness, and many other chronic diseases are also linked to smoking. But what's important is even to think beyond just the health consequences, because there's many ways that tobacco also negatively impacts people's lives, which may be worse if you have a mental illness. Using this drug contributes to financial hardships. It's expensive to smoke cigarettes. It makes it harder to get a job. It makes it harder to get and stay in your housing. There's a lot of evidence now that smokers have worse mental health and more relapse back to drugs and alcohol. One way that's measured is that smoking is associated with higher rates of suicidal ideation and suicide attempts. There's a stigma in being a smoker. It worsens your appearance. It's the #1 cause of house fires. So many, many ways that it negatively impacts people's lives and their successful life in the community in particular. There's also data showing that cigarette smoking is the #1 cause of death in people with behavioral health conditions. There was a study done in Canada which actually tracked people with schizophrenia, depression, and bipolar disorder, and showed that smoking accounted for 50% of all the deaths in this population. The graph on the right is showing that populations with opioid use disorder also over their lifetime are more likely to die of diseases linked to tobacco than really any other cause, including overdoses. Similarly, in a study of people with alcohol use disorder, alcoholics die more of smoking diseases than even of things that are directly linked to alcohol. So really alarming statistics, and overwhelmingly show that it's the #1 cause of death in the people we serve. We often hear about higher risk of cardiovascular disease in particular, or metabolic syndrome in our patients. And I just want to remind people that although there's many risks that contribute, risk factors that may contribute to your developing cardiovascular disease or metabolic syndrome, that in fact smoking is still the single most important one. If you're able to stop smoking, it reduces your risk for having those problems by 60%, which is more important than any of the other single risk factors. And so I think it's where we really should be putting more emphasis in terms of addressing these deadly syndromes. Smoking is also a barrier to recovery and inclusion in the community because of some of the reasons that I discussed. It impacts your ability to pay your bills, stay in your housing, especially if your housing is smoke-free. And so it may jeopardize your housing. It may affect your ability to form relationships or even date, limit your participation in community activities, which often don't allow tobacco, etc. So many ways that it's really a barrier to recovery and inclusion. As I mentioned, there's really now compelling evidence that smokers have higher risk for suicidal ideation, making specific suicide plans, making suicide attempts, and even dying by suicide. This was shown in a recent meta-analysis. But in many other ways, smoking is also linked to more severe symptoms of mental illness, whether that's depression or schizophrenia or anxiety. Smoking is generally linked to an earlier onset and a worse prognosis in youth who may also have mental health problems, as well as more substance use and more relapse back to drugs and alcohol. So although there was this old myth that somehow smoking helped people with mental illness or acted like a medication, there's really no evidence that that's true. And the overwhelming evidence is that smoking is associated with worse mental health outcomes. Again, this was another meta-analysis looking at the impact of quitting smoking, showing that overwhelmingly in people who are able to quit smoking, they subsequently reported lower levels of anxiety, lower levels of depression, lower levels of stress once they quit smoking, as well as better quality of life and better mood. So not only is smoking associated with worse mental health, but when you're able to quit, mental health symptoms, stress, quality of life also do seem to improve. There's a lot of evidence linking smoking to anxiety disorders. Smokers have 3 times the risk for developing panic attacks in epidemiologic and clinical studies. People with anxiety disorders, as with many of the conditions that I'm going to speak about, have less success in quitting smoking on a given attempt and may experience even more withdrawal symptoms. So again, this idea that people need to smoke because somehow it's relieving their anxiety doesn't seem to be true when we look at research data, because smoking seems to be associated with higher levels of anxiety. One reason why people may perceive this to be true is that when you look at the list of tobacco withdrawal symptoms, it includes anxiety as one of the drug withdrawal syndromes. And as with any drug withdrawal, if you use your drug, you temporarily feel better or alleviate those symptoms. And so if you're in withdrawal and you smoke a cigarette, temporarily you may feel like your anxiety got better, but really that's not giving you a significant improvement in anxiety. It's just taking you in and out of drug withdrawal. So why is it so hard to quit this drug? Sometimes people will say it's the hardest drug that they've ever quit, although they've had success in quitting other substances. Well, it is highly addicting to smoke a drug in particular, in terms of how the drug is delivered to your brain, and that may be a contributing factor. There's easy access to this drug, of course, which is legal in our society. In fact, it's normalized in many of our treatment settings, and maybe we haven't always done enough to intervene. In general, treatment options are limited for how people might access care to quit smoking, and we often give people only very brief treatment or limited medications. Even though we know that these treatments work, utilization tends to be poor. So we might offer them to people who then opt to try and still quit on their own. They may not use the counseling. They may use the medications at too low of a dose or not for a long enough time period. So we really want to teach people about the benefit of treatment, how it enhances outcomes and can help people to be more successful. Again, we're thinking about this issue specifically in the culture of care of the behavioral health treatment system and trying to change that system. Sometimes buy-in for this issue remains low. It can be a complicated issue to take on as a program. Historically, although hopefully not anymore, we used smoking as a reward for people for good behavior. It was also accepted as a shared social activity, or a belief that this was somehow what medical teams did and not the mental health team, not within our scope of practice. The systems honestly are stressed. People have a lot to do. Often we're understaffed, but there's a lot of evidence that we can be quite effective in delivering these treatments, and we have many of the skills needed to deliver them effectively. In addition, there's considerable evidence that our patients are quite motivated and actually want these treatments when we deliver them. So just to remind people, tobacco use disorder is in the DSM-5 because it meets all the criteria for an addiction. It is a substance use disorder. The drug of nicotine impacts the brain reward pathways much in the same way as cocaine, heroin, and other drugs. So it meets every definition of being an addiction, and therefore in the DSM-5 would be within the scope of practice of people that work in behavioral health. I mentioned that when you smoke a drug, it's a very efficient way to deliver a drug to your brain. In fact, you may be surprised that it is equivalent essentially to IV drug use. We think about shooting up a drug into your vein intravenously as a very highly addicting way to use a drug. We think about those people as sort of having hardcore or the most severe forms of addiction. Yet when you smoke a drug and you deliver drug through your lung, you essentially get the same impact as you do with shooting up. In fact, it may even be slightly faster to smoke drug because the lung is so able to soak up a massive amount of drug almost instantly through the many capillaries that line the lung. So that huge absorption of blood vessels can take in a lot of drug very quickly. And from your lung, it's literally a very short distance to deliver the drug to your brain. So you really feel that hit of that cigarette very directly. And the cigarette is quite good at delivering a large amount of drug to the brain, which contributes to its addiction potential and is a much faster way to deliver drug to the body compared with, say, eating a drug, which has a much slower onset. These are the symptoms of tobacco withdrawal. So within hours of someone's last cigarette, if they are a regular tobacco user, they can develop a low or depressed mood, irritability, frustration or anger, feeling of anxiety, trouble concentrating, restlessness. They can feel hungry and they can have urges or cravings to use the drug. If they quit over several days, they may also experience insomnia or trouble sleeping. These symptoms can be quite upsetting to people, quite uncomfortable to tolerate. They lead a lot of people back to using their drug or relapsing back to smoking, and they can persist for at least weeks after someone tries to stop using tobacco. As I mentioned, there's a lot of evidence that patients with behavioral health conditions are really just as motivated to stop smoking as other smokers in the United States. So it may be a myth that our patients don't want to quit. There's tremendous evidence that they do want to quit and they're receptive when we offer treatments. And as many as 20 to 25% may be really ready for some type of intervention and looking to take steps in the near future. Although statistics unfortunately show that we're not doing enough, with even recent data from 2016, this is a national survey done by SAMHSA and the CDC, looking at state level data. How much do we intervene for tobacco in mental health and substance abuse treatment facilities? And unfortunately, we're still not doing enough. As recently as 2016, less than half of all mental health treatment facilities in the United States even screened for tobacco, which means we don't even ask about tobacco half of the time. And as you can imagine, if you don't ask about it, the rates of intervention are going to be lower still, which is what you see in this table. And they're similarly low in substance abuse treatment facilities. So we still have a long way to go in terms of implementing treatment systematically. So what's new in the area of treatment of tobacco use disorder? I won't have time to review all of these concepts, but just to give you some idea that there is a lot of new and emerging practices in this area. Some of the newness is really around messaging and the language that we use and really referring to these services more as treatment, trying to eliminate words like cessation, which can be sort of negatively charged for people and imply that there's really only one outcome, when really there can be more of a range of outcomes and more of a harm reduction approach. There's been more aggressive use generally of pharmacology, as well as increased access to the psychopharmacology for treating tobacco use disorder, and that's all very positive. And I'll speak about some of that today, including more of a first-line approach of different treatment options. Again, in terms of harm reduction, trying to do anything generally to increase engagement, using your motivational skills, encouraging people to try treatment, to reduce their smoking, even if they're not able to commit to abstinence. And really this growing area about considering non-combustible products, including things like e-cigarettes, for some people who are really unable to quit with other means. There's been some advances in counseling with evidence that ACT or acceptance and commitment therapy can be helpful, as well as a specialty certification in becoming a tobacco treatment specialist if that's of interest to you. So treatment works. That's a really positive message that we should share with patients. Again, referring to it as treatment and not cessation, thinking about this condition as a co-occurring disorder, as a chronic illness. So where we're always trying to intervene whenever we can, but techniques like brief assessment can be helpful. We want the message to be that we want to work with all tobacco users, not only those who are ready to quit. So we should have skills and techniques for working with people at different motivational levels, with a lot of emphasis on engagement and motivational approaches supporting our treatment, as well as giving people action-oriented treatment with counseling and medications when they're ready for that option. So I'm jumping around a little bit in this presentation, but I want to give you an overview of a lot of basic ideas. So I'll talk a little bit now about assessment. And when you're assessing people for their tobacco use disorder, there's lots of ways you can do assessment, but even if you only have time for one question, I would encourage you to ask people this one. It's called the TTFC, or the time to first cigarette. Basically, you're asking people how many minutes in the morning until they use tobacco or smoke their first cigarette. And the faster that they do that, the more addicted they are. So that turns out to be a really helpful measure with a lot of clinical relevance. If someone smokes in the first 30 minutes of waking up in the morning, they are at least moderately nicotine dependent. And that's a good crude estimate that the person really will need medications to be successful in quitting. They will struggle without medication because of the higher level of a physiologic dependence that they have. Many patients will actually tell you they smoke in the first 5 minutes of waking up in the morning, which is an indicator of more severe nicotine dependence. So this measure is very quick and easy to assess, and it tells you something about their level of addiction, which has implications for their treatment outcome, their need for medication, and maybe even a need for more intensive treatment or higher doses. If you're able to access a carbon monoxide meter, this is also a useful way to do assessment. Generally, the more people smoke, the more carbon monoxide they get into their body, and you can measure that with a handheld meter. Carbon monoxide comes from anything that burns, including cigarettes. It's a product of combustion. And what carbon monoxide does in the body is it puts a burden on the heart. It reduces the oxygen level in the blood. Heart has to pump harder to move oxygen around, which creates strain and increases someone's risk that they'll have a heart attack, stroke, or other cardiovascular disease. It's a way of giving people feedback. Not only is an assessment of how much they smoke, but it's a really nice way to give people feedback about one way that smoking is hurting them today, which for some people, they find that as a very motivating message to understand some of the harm that smoking may be doing to them, giving them this feedback. But the other thing about carbon monoxide that makes it very clinically useful to talk about is that this is a very reversible effect because your body's always making new red blood cells. If you quit smoking today, by next week, your carbon monoxide level will be 0 or back to normal. So therefore, it can give people hope that it's really never too late to change. It's always better to try to quit. Even if you're at an older age, you can always reduce your risk for having a heart attack by quitting at any age. So it serves all these purposes of being a motivator, providing some assessment, and then you can also confirm that someone quit by measuring this level over time. So I'm just going to give a very brief review of some of the highlights of treatment. There are several FDA-approved medication treatments that we can use for people with tobacco use disorder. Many of them are alternative forms of nicotine, which have the carcinogens and toxins removed. And many of these nicotine medicines are also over the counter, which means any of us could walk into a drugstore and buy them. Although I will encourage you to write a prescription for your patients, even though these medicines technically are over the counter, patients will be able to access them generally for free in New York with their Medicaid if they're able to have a prescription. So the nicotine forms of nicotine medication, which are referred to as nicotine replacement therapy or NRT, include the patch, the gum, the lozenge, the oral spray, the inhaler, and the nasal spray. Technically, the oral spray is not out yet, but should be out sometime soon. There's also non-nicotine treatments which are available, including bupropion, which is the same thing as Wellbutrin, or varenicline, which is sold under the name of Chantix. All of these medications work in helping people to quit smoking, and all are better than a no medication or placebo option. So they generally double your chances that you'll successfully quit smoking compared with if you didn't use medication. Out of all of them, you can see varenicline actually has an odds ratio of 3, which suggests that it triples your chances. So when used as a monotherapy or as a single agent, there is evidence that varenicline is more effective than the other treatments. But they all do work and have been studied extensively. The reason that we use medication, the rationale is to reduce or eliminate the uncomfortable symptoms of tobacco withdrawal. These really will undermine someone's ability to successfully quit. The medications do other things as well. They lessen or delay the weight gain that people experience. Remember that feeling hungry was one of the nicotine withdrawal symptoms. So if we can reduce that sense of hunger, people generally gain less weight when they use the medications to quit smoking. The medicines also block some of the enjoyment from smoking. So that's why we can use them in harm reduction paradigms, because they're also reducing the pleasure from smoking, which can help people to further reduce and perhaps even quit their smoking over time. Excuse me. And these have been studied extensively, as I mentioned, and are a cost-effective treatment. When we're using these medications, generally, we want to recommend that the best treatment plan for everyone is to use them in combination with counseling. So the best outcomes are associated with people that received both counseling and medication treatments together. But both of these treatments are also effective when delivered alone. So if some people only want counseling or only want medication, that's certainly better than no treatment. The way we think about nicotine medications is that we have to use them somewhat aggressively to get a better outcome. We want to tell people to use enough of them so that they feel comfortable. Remember that the cigarette is very good at putting nicotine in the body, better than these medications. So you have to overcome that by using enough of these medications for them to work, encouraging people to use them all day long in a high enough dose and for a long enough time period. You can give people 2 nicotine medications at once that I'll talk about. Nicotine is safe enough to be over the counter. It does not have any interactions with people's medication. And there's also a lot of evidence that nicotine medication is safe, even in people with a past history of some kind of cardiovascular disease. The FDA issued some updates in terms of the language around licensing these medications several years ago, again, to put out more support for safety. So according to the FDA, there's no significant safety concerns with using more than 1 nicotine replacement at a time. There's no safety concerns with using nicotine even when people are smoking some cigarettes, and use beyond 12 weeks is considered safe. One key aspect of using nicotine effectively is giving people education about how to use the products. Many of the products are delivered through the lining of the mouth. What happens is that the nicotine has to hang around in your mouth long enough to have time to soak through the lining of your cheek. That's how it is delivered to the bloodstream. As you can imagine, a lot of things can go wrong. And so we really want to teach people to use the right product and to use it the right way so that nicotine is delivered effectively and has a desired effect. So education, again, really goes a long way. In terms of the gum, there's a specific technique to teach people, which is to really chew the nicotine gum very slowly. You should just bite the gum until it releases the peppery taste, which is the nicotine. You should then hold the gum in the lining of your cheek to allow some time for the nicotine to be absorbed from your saliva, again, through the lining of your cheek, which is generally a slow process. The slower you chew the gum and the longer it takes for you to do that, generally the more product you will absorb, the more nicotine you will absorb, and maybe the better the product will actually work. Because many of these products are considered low delivery nicotine products, they don't deliver a lot of nicotine. They often come in a 2 milligram and a 4 milligram strength. And we encourage people to use the 4 milligram version, say, of the gum or the lozenge, so that each piece delivers approximately 1 cigarette's worth of nicotine. But as you can imagine, for these products to really work, you have to be using them throughout the day with additional doses for craving. Side effects from the oral nicotine products are generally very mild. They can include an irritation in the mouth or throat. And if someone tells you they're experiencing hiccups, they're generally swallowing too much of the nicotine in the stomach and having that side effect. So the oral forms include the gum, the lozenge, the oral spray, as well as the inhaler, which generally all deliver nicotine to the lining of the mouth. There's a lot of evidence now that 2 nicotine products is better than 1. When we give people so-called combination NRT, they're able to deliver a higher dose of nicotine to their body, which generally gives them better relief of craving and withdrawal. This is generally done by recommending that someone wear a long-acting product like the nicotine patch and supplement throughout the day with a short-acting form of nicotine replacement, any of the oral ones that I just discussed. And when people use combination of 2 nicotine products, again, it essentially doubles the chances that they'll successfully quit compared with if they only used 1. There's been a lot of research studies looking at varenicline as an aid to help people to quit smoking. This was really a famous trial now that was conducted called the Eagle study and published results published in 2016. It was a very large study of more than 8,000 smokers, which showed that varenicline was effective in helping people to quit smoking. In fact, it was more effective than if they took bupropion or a nicotine patch. This study also included 4,000 people who had a known mental illness. And even in the mental health or psychiatric group, which is the middle part of this graph, we see that varenicline is also the most effective treatment for that group as well. Although we see that the overall success rates, which is what this graph is showing, are slightly less for those who have psychiatric illness compared on the left with those that don't have psychiatric illness. So the take-home messages here are that our patients can quit smoking. They can quit smoking certainly with varenicline or any of the treatments that I'm talking about. There is evidence varenicline is the most effective, but that overall success may be lower in people with a mental illness. This study was really done to look at the safety of varenicline and its ability to cause neuropsychiatric side effects. So it had a negative finding in that there was really no evidence that people who got varenicline treatment had more moderate or severe adverse events compared with people who got the patch or bupropion or who even got placebos, which were blank medication treatments. So there was actually no evidence from this very large study that varenicline caused people to feel suicidal, depressed, psychotic. The study included a whole range of different psychiatric side effects, and there was no evidence that the people who received varenicline had a higher risk for developing those side effects. That's not the only study that has looked at this. There's other studies with up to 10,000 patients also showing that varenicline did not increase the risk for suicide, suicidal ideation, depression, irritability, or aggression. There's been some interesting analyses published looking at healthcare data to show that populations who were treated with varenicline actually were less likely to be hospitalized in the subsequent year for any kind of cardiovascular disease or psychiatric illness. Again, suggesting that if these populations receive varenicline and are able to quit smoking, that they have subsequent better health and mental health outcomes. So again, supporting this idea that varenicline is quite safe and doesn't worsen these conditions. So now we have a lot of evidence that there's two treatments that are really better than the rest. That's why I emphasize them in this brief webinar today. Varenicline or combination NRT really are superior to the other medication strategies. And we really should think of these as first-line treatment options when we talk to people about treatment, that these treatments are better, say, than single nicotine replacement or bupropion. And we can really think about this as a first-line algorithm. These treatments have been studied in mental health populations and have been shown to work. They're generally well tolerated, although I mentioned that the overall success in quitting can be lower in populations with behavioral health conditions. There's been many studies that show in general, when people try to quit smoking, it doesn't worsen their depression or their schizophrenia. So that's also good to know, in addition to the safety of the medications like varenicline. And there's probably a role for a modified coaching or counseling approach. People may need more sessions, more support to be ultimately successful in quitting smoking. Similarly, with substance using populations, there's evidence these treatments work and they're well tolerated. Populations with a history of alcohol use disorder, if they've been able to successfully quit alcohol, there's evidence that they're just as likely to quit smoking as any other smoker. I mentioned already that those who continue to smoke actually have higher risk of relapse back to their primary drug or alcohol, and that quitting smoking overall improves abstinence outcomes and probably should be integrated more into other substance use treatment. There's some interesting evidence that varenicline also reduces drinking in addition to improving smoking outcomes. The way that varenicline has its the way that it works is by impacting the brain reward pathway. It reduces some of the reward from smoking. And because that's a common pathway for all drugs of addiction, it has the potential really to reduce reward from other substance use. People are studying it for other types of substance use disorder. And there's evidence from a human and animal studies that it reduces reward in drinking and also reduces drinking in a variety of studies. In terms of counseling, we do want to be able to provide people counseling. Who better than people who work in behavioral health treatment settings, because we are counselors and we're also very familiar with the kinds of approaches that help people to quit smoking, like relapse prevention and cognitive behavioral strategies. There may be a role for the free telephone quit line in what we do. Certainly any counseling is better than no counseling at all. But in general, there may be some limitations to the telephone quit line in that it's quite brief treatment. In general, most state quit lines only give people an assessment session and up to 4 follow-up calls. Our patients may need more support and counseling than that, but there can be some advantages with the quit line. It's available in many languages. You don't need transportation. It's generally free. You can do it from your home. So there's sort of advantages and disadvantages, but I do worry that in the patients we serve, there could be issues with trust and relationship that make it hard for people to call this counselor that they don't know over the phone. I always think we would be better, our patients would be better served if we provided the counseling, since they already have relationships with us. It would link their tobacco treatment to their primary team, and also be able to give them perhaps more intensive and more total number of sessions. Just very briefly to mention a few points about electronic cigarettes and vaping. In general, what an electronic cigarette does is deliver nicotine to someone's body. The nicotine is generally heated and creates some kind of a mist or vape but technically there's no burning, there's no combustion. So there's no products of combustion associated with this product. There's no carbon monoxide. And in general, studies have shown that the amount of toxin exposure from an e-cigarette is about 1% or 1/100th of the amount that someone would get from smoking traditional cigarettes. So we can't say that these are completely without harm. Certainly there may be some risk for harm, but the overall amount of harm does seem to be much less compared to a combustible cigarette. So there's kind of growing evidence that they may play some role for cessation in some older smokers who have not been able to quit with traditional methods. That of course has to be balanced in our society with the considerable risk that these products show to young populations. We've had explosion of vaping in young populations, which then increase the risk for these individuals to go on to smoke traditional cigarettes, use cannabis and other drugs. And so it's always hard to sort of weigh these different considerations. And that's why these products are very controversial in this country. In addition, they're currently not regulated. The FDA has begun to test and give some sanction to some products, but most products that are currently available have not been regulated and we don't really know what's in them. So again, safer than smoking doesn't mean that they're entirely safe. We certainly had cases of EVALI emerge several years ago, lung injury associated with the use of vaping devices, which was linked to a contaminant, which again supports this idea that we need testing and regulation so that people at least know what the risk is and what they may be putting into their body. Certainly when people use these products, they can continue to be addicted to nicotine. And we do see young people who have significant nicotine addiction from e-cigarettes. And we don't know a lot about what works in terms of helping these people to quit, but we can use our clinical judgment in traditional treatments, which should work because nicotine addiction is similar across these different devices. And then the last sort of concern is sort of vaping culture, which again is growing, public perception. There's a lot of co-use with THC and cannabis products, and that also further complicates sort of the landscape in talking about vaping and the use of e-cigarettes. So several considerations just to keep in mind. So as I mentioned, the TCTAC team is available in New York to help you implement these kinds of practices for tobacco use disorder. And I'm going to now turn the program over to my colleagues Noel Lipton and Rusty Foster, who will continue to talk about ways to implement these strategies. Thank you.
Thank you, Jill. And let me put this on. That was quite a wonderful presentation. I always appreciate it no matter how many times I hear it. And so that's an overview of the issues related to smoking. And I'm going to start off by talking a little bit about if you were interested in implementing tobacco use disorder treatment in your program, how would you go about it? Okay, what's the best way to do that? And so we have lots of information on our TCTAC website. And we're going to first look at this kind of map, this kind of the way you take steps to implement this change. And we use the Plan, Do, Study, Act methodology, which is a methodology that's been around for a while. It's used in many settings around making changes and improving how you provide services. And so plan is, right, you like plan. What are you going to do? Right, plan. And then do, even though it looks like a small word and it should be easy to take advantage of, that's where you put it into action. That's where you really try to make the changes that are in your plan. Then as you're doing this, you're studying the results, and then you're going to based on the data, the measures that you collect, you're going to act on them, which means that the things that you plan to do that are been successful, you're going to try to embed those in your program and maintain them over time. The things that didn't work as well in your plan that you wanted to do, you just revisit your plan. Can we do, is this something we can't do right now? Is this something that we understand what got in the way and we're going to make some changes, and so we're going to update our plan? So we use plan, do, study, act as a process of implementing change. And then the other way to look at this are these steps. So the first step that we recommend is that you complete the TSET. And the TSET is the Tobacco Integration Self-Evaluation Tool. And that's something that we're going to talk about in more detail in a few minutes. But when you do that, there's a number of areas that you get to look at that are related to providing tobacco use disorder treatment that you can then say, we're pretty good at this in this one area. And these are like kind of important, essential elements in tobacco use disorder treatment. We're pretty good at that. And maybe we could try to get better, but we feel pretty good about what we're doing there. But in another area, you say, we are not doing that well. And we maybe can do some improvements there. So this gives you some real, you're doing the self-evaluation, but it's really in some ways some objective, measures of how you're doing and what you might want to work on. So from that, and say, we want to get better at being smoke-free environment, then you develop an implementation plan. So those are areas that are going to be actually your goals. And when you develop an implementation plan, it's the Plan, Do, Study Act, right? You're gonna plan what you want to do to improve what was shown in the TSET to be something that you're not really implementing completely. And then you're gonna follow the plan. You're gonna do it, study, and act. And finally, and this is in the our TCTTAC website, we have a roadmap. And the roadmap has two things. One, there are steps to doing implementation. And, this comes from our experience and from the literature, but, it's things like getting buy-in from your leadership, developing a work group, etc. So it gives you a roadmap and how to really put this plan, to give this plan some ability to be successful. Okay, so this is the roadmap, and you can see the arrow comes back, because what happens is, as you're doing the plan, you're going to look at what you're doing, you're going to get feedback from the results, and you're going to maybe change the plan. Okay, so the roadmap is also a compendium of resources and tools that you would be able to use, and that would be very helpful if you decide implementing tobacco use disorder treatment is something that you want to do in your program. So okay. So this is the self-evaluation tool, and this is I love this tool. They're not quite fidelity scales, but they're like fidelity scales, and it really goes through areas that you're going to want to look at in terms of how you're providing tobacco use disorder treatment now. Okay, you might already be involved on some level in doing that, but this gives you a more objective, and it's based on the dual diagnosis capability and mental health treatment, the DD-MUT it's called. And that was a way of looking at how you provide integrated mental health and substance use disorder treatment in general. Okay, and this is a modification of that. It has 6 domains: policies and administration, environment, screen, do we have signs up, no smoking signs, screening and assessment, treatment, staff and training. There's a number of items in each of those domains, a total of 20 items. And you look at those items and you would rate that on a 5-point response. Okay, so it goes from 1, we haven't implemented this, to 5, this is fully implemented. We fully do this. Okay, are you prescribing NRT? Are NRTs being prescribed? No, we're not doing that at all. That's a 1. Yes, we'll do it all the time. That's a 5. And then based on that, of course, you can then say, how could we move this from, we got a 2 in this, how can we move this to a 3? Okay, it doesn't have to be a giant leap, but a 3. And then you develop action steps. What are you gonna do to do that? So I always recommend that any program that's interested in implementing tobacco use disorder treatment should use, the first step, you should use the TCET. And when you're doing this, these are some of the questions that you try to answer, okay? What is our overall capacity for treating tobacco use today? Okay, and it's always today. It's not we used to do this or we want to do this. It's what is happening now. So what is our capacity right now for providing tobacco use disorder treatment? How can we increase our capacity? Okay, over time. And over time is an important concept, because you're not going to do, it's not going to happen overnight. You're not just going to magically do it. It's going to take some work. It's going to take a plan. You're going to need to look at how to measure whether you've been successful. And you're not going to start everywhere. You're not going to start in everything. You're going to pick maybe 3 things that you want to improve and work there. And then how do we develop and implement a plan? We talked a lot about implementing a plan. Developing a plan is extremely important in the process of integrating tobacco use disorder treatment in your program. How do we know our changes have been successful? That's very important, because, my sense is anyone has done treatment plans with people that are receiving services, they need to know, and you need to know, are the plans working? Are they being successful? Are they going in the direction that that person wants? So this is our plan being successful in what we're looking for? And you might also make sure that you look at the organization's policies, clinical practices, workforce capacities, sometimes it's important to embed these changes, not just in through training, but more than that. And it's like through policies and procedures, through orientation, through how you supervise. All those things help support the implementation process. And then you have to figure out how to get feedback on your priority areas and whether you really are achieving what you were looking for. So, I've been doing this a while. I don't know why. I always have fun thinking about this. It's not quite easy because sometimes there's some challenges that you run up against, but it's really it's really interesting to do. And the other thing is, when you do it, I always try to keep in mind that it's going to really help the people that we provide services for. And this is when you do if you do a TCET, we could send you a Qualtrics form. You could enter your rating numbers into the form, send them to us. We can do graphs. We can compare it if you had more than one program in your agency doing it. You can compare it against the total agency average on each item. We also say, hey, you got a 4 on this item, that, that's really great. Okay. But sometimes it'll say, we got a 3, and we might say, well, here's some things you might consider doing if you want to go from a 3 to a 4. Okay. So in the report, we give some recommendation. We give you your scores, and then we give you recommendations for change. And now I'm going to turn it over to Noah.
Okay. All right. Thank you, Rusty. And also thank you, Jill, for that great presentation earlier. Let me move on to the next slide here. So Jill referenced this at the beginning, that although there's a wonderful, I think, breadth and depth of information in this webinar, there's a lot more that we include in our full length kind of intensive training, which we really recommend for providers of services at your programs, even for administrators, because there's really so much that goes into this that could potentially be implemented, as Rusty referenced, that is part of the TSET that you may want to move forward with in terms of developing your plan. So the training, as was most recently offered due to the COVID-19 pandemic, was virtual, but live, and 12 hours in total, broken up over 4 days. So 3 hours over the course of 4 days, and broken up into 2 parts. The first part being led by Jill Williams, talking about understanding the problem of tobacco use among this population, and what works. What are some of the things we know that have been helpful, and we certainly got a taste of that today, as to some of the things that have shown beyond promise, that have actually worked quite successfully with this population that lives with serious psychological distress or mental illness. So it's touching on things like epidemiology of tobacco use in vulnerable populations, tobacco as an addiction, evidence-based counseling treatments, as well as medication treatments, harm reduction strategies, and emerging products. And I'll just say, from having been able to experience Jill's training over the years, it's also continually evolving as we learn more about new products, about what's effective. New studies are being done all the time. So we're also constantly trying to update and keep current, the information that we're sharing with the various folks that are attending our trainings. So that really, I think, establishes a great foundation for people that attend and how to understand this challenge, right? That has been something that folks that we're working with have dealt with for, oftentimes for quite a while. There hasn't been, as Jill referenced, much of a dent in terms of the rate of smoking. It's hovers somewhere between 40% or so, 35% for our population, whereas it's dropped quite a bit, considerably, in the range of 14-15% for those, at least in New York, for those that don't have serious psychological distress. So there's a great need to continue to work on this and put some of these things into practice. Building on that foundation, the second part of the training, and let me move to the next slide here, is really focusing on a particular way of having these conversations with our recipients, with our participants, that helps folks to begin thinking, if they haven't already, about making these changes, what that would mean for them, what some of the benefits might be, as well as perhaps what some of the barriers might be, and how we can begin to think about that. What might some of the first steps be? Where do you see yourself in a few years if you were able to make a change to your smoking, either cutting down or quitting, and really building on that kind of questioning and sort of brainstorming to develop some strategies, hopefully, down the road. So with motivational interviewing, we look at things like, how do we help people make changes in general? What have kind of studies shown in terms of these types of conversations, and how, we know that if we're coming in, very strongly, and we're the ones that are bringing, all the reasons and the impetus and the need to make the change, that's often not going to hit home for people that are ambivalent about making the change, right? They may have reasons to do it, but they also may have reasons that they really like it. As Jill referenced, folks feel like it may help them with their anxiety, or helps them calm down, or helps them socialize, right? So there may be some really strong reasons that they hold on to it. So we need to hear that. We need to make space for that, while also hopefully also creating space to hear some of the things that maybe they don't like about it, right? Whether it's the cost, whether it's health effects, whether it's, discoloration to their teeth or fingernails or whatever it might be. So what are some of the things that help us have these conversations? Moving on to the spirit of motivational interviewing, which is really important. It has to do with things like acceptance, collaboration, evocation, really recognizing that the person that we're working with is an expert in terms of their lives and how they've gotten to this place and their strengths, their resiliency, as well as some of the things that perhaps get in the way of pursuing their goals. So that's also, I think, really foundational to these conversations. Moving on to core MI skills, which are things like open-ended questions, affirmations, reflections, and summaries. That really captures kind of the first part of our MI training. And then the second part is delving a little bit deeper and building on those skills that we've practiced, that we've honed a little bit in that first day. How do we begin to really use those strategically to help people talk about making this change and what that would mean to them? How do we elicit that from folks? How do we strengthen that? Because what evidence has shown is that the more that we're doing that, the more people are expressing that kind of talk and hopefully eventually also taking actions, that's predictive of future change. So we focus a lot on that. And then we all, we know that there's a lot of people, we mentioned that the rate of smoking is quite high for this population. Unfortunately, there's a lot of sustained talk. There's a lot of things we hear that reflects that folks aren't open to making this change, or there's a lot of reluctance or ambivalence, right, to doing that. So how do we respond to that? What are helpful ways of engaging in these conversations, even with folks that may feel more on the fence about it, so that, we're not causing folks to feel like they have to back off and want to run away, but we can engage with them, even if they're in a place where they're not quite open to the change at this point. And finally, for those folks that are moving more into preparation action, how can we put a plan together that the person feels that they can really buy into, that feels doable, that recognizes some of the small steps along the way that hopefully may eventually lead the person to, make a substantial change in their, how much they smoke, or even eventually quit, hopefully down the road. And we do use a lot of discussion and practice role plays, particularly for the second part, motivational interviewing, because that's really important, right? To practice these things, see how they sound. Rusty and I, provide a lot of feedback in terms of, how folks are doing, and often folks are coming, with some expertise already in motivational interviewing, and a lot of, practice and experience working with people every day. And we just might add, our 2 cents in terms of what might make it just a little bit better. So that really makes up the training that we offer. In addition to that, and this is, I think, the training is certainly so important, but really what follows that, I think, or even could come before that, is the technical assistance, which is, I think, also equally important. And that can be done, live in person as we used to do it, or certainly virtually. And also a ton of resources available on our website, which we'll introduce very shortly. So we work with programs, and we really try to do this in an individualized way. Like, where are our programs? What are their goals? What are the things they'd like to work on? Are there particular staff in their agencies that they want to help develop these skills in particular? So wherever folks are, that's we certainly meet programs where they are. As Rusty spoke about, we certainly help programs or agencies walk through the TCET process, of taking the TCET, understanding what it means. We provide those reports, developing implementation plans based on that. That's a big part of the assistance we offer. We love to be a part of regular work group meetings. If you have a work group at your program or agency that's really focused on tobacco, we would love to be invited to those meetings, or at least some of those meetings, to perhaps continue to provide any information or guidance that we can around helping to make these changes. We might look at, for example, your policies and practices. Jill in particular has a great deal of experience doing this in various states across the country, helping them to implement these policies, and then how do we back them up, right? Because of course you need the follow through to really make them to sort of prove the the value of them in the practice is the follow through. Assist in developing an implementation plan, as we spoke about, support ongoing efforts and troubleshoot any barriers that might come up, provide extensive resources like handouts, teaching tools, archived webinars, and we also like to, of course, continue the communication in an ongoing way by we host a listserv where we provide new updates, new information, new resources that we've developed or identified that we think will be helpful. Rusty talked about this a little bit earlier, but our roadmap has just a wealth of resources that really line up with the TSET. So whatever areas you identify that you'd like to improve upon, there's just a breadth of resources related to that. Everything from sample policies to assessments to curricula that you might use for groups, for example. There's really anything you might want. I mean, hopefully, and let us know if there's any gaps. But really, we've tried to be very thorough in either developing or identifying resources that are available to helping your programs move forward in any way they might want to. This is our website. We've recently kind of worked on it, tweaked it, improved it, we hope, to allow folks to search, for example, for any tool they might want. So there's now kind of a searchable index of all those tools. There's up-to-date information on how to get in touch with us, on training dates that are coming up. So lots of different things available there, and we certainly would encourage you to take a look at that, and it should be up and running very soon. So we're really excited about launching that. As we've said, there's also a great deal of educational resources. This is an example of handouts that we've developed, or that Jill's developed around these NRTs and medications for supporting people, in their efforts to either cut down or stop smoking. And these are also available, as you can see, in 7 languages in addition to English, representing the 7 most spoken languages in New York City, after English. So we really try to make things accessible to the various populations that we know all of you are working with across the city. Finally, in conclusion, just to highlight a few of the points that were made, it's the smoke that kills. In terms of the actual dangers of smoking, we approach tobacco use as a co-occurring disorder. So we really see it as, and as Jill referenced, right, it is as deadly, if not more, than some of the other addictions or substances that people are using. So we really encourage programs to view it that way and to address it as seriously as other substances they might be addressing. To think about medications for anyone that is smoking soon after waking up, that's an indication of the severity of the person's addiction. Varenicline or combination NRT are 2 very good medication options. Implementing system changes will help to support treatment, for tobacco use disorder. And we hope that one of the next steps you undertake is to partner with us in your efforts to make these changes. So we just want to thank you on behalf of the TICTAC team, Jill Williams, Rusty Foster, Nancy Koval, and myself. We really want to thank you for taking the time to watch this, and we really hope to hear from you and partner with you in the future. So, take care.